We may have another ICU admission. I'll call to confirm. Okay.
Dr. Collins, do you think that we might be able...
Drowning victim here. Not right now.
Amber Phillips, 6 years old, found at the bottom of a home pool with an unknown downtime. Asystole on the monitor.
Intubated with a cuff 4.5, 22 gauge left AC, 0.25 epi 3 minutes ago.
1, 2, 3.
So to recap, we have a 6-year-old girl by the name of Amber found in a home pool with an unknown downtime. Asystole on the monitor when EMS arrived at the house. The patient's coming in CPR in progress and is intubated already with a cuffed 4.5 endotracheal tube. We have IV access with a 22 gauge to left AC, 0.25 milligrams of epinephrine given 3 minutes prior to arrival via EMS. And so here EMS is following the Pediatric Advanced Life Support, so PALS, which itself is an entire course. Now they state 0.25 milligrams of IV epinephrine. That's because the cardiac arrest dose of epinephrine for a child is 0.01 milligrams per kilogram. So to put that in perspective, for adults that go into arrest, we just give them a milligram. So in this case, they gave 0.25 milligrams. The dose is 0.01 milligrams per kilogram. And so if we want to just kind of get into technicalities of that, what they gave, and kind of backtrack a little bit, that means that child is roughly 25 kilos or 55 pounds. Now, when pediatric patients come into the ER, let's say pediatric patient's sick, they're coming through the front door. Let's say actually they come through the front door, they are cyanotic, they're purple, they're not breathing. Let's say they have no pulse. I need that child back immediately. We get them on the bed, we start CPR, we're doing these things, and we'll eventually get a weight on that patient, but I need meds right now. So what we do is we actually roll out something called a Braslo tape. We have the pediatric crash cart, we bring that out, we have a Braslo tape on it, and you roll that tape out. What that's doing is it's corresponding to the height or length of the patient. And so it's going to give us a color. So this first one that I'm going to do, for example, is we're just going to pick a random one. We're not going to base it on the episode. We're just going to kind of pick a random one. And so let's say it's yellow. We have that child down, we have the tape laid out, and the length of that patient falls on yellow. And so that tells me that child is roughly 12 to 14 kilos. Obviously, weight's going to change. These are all estimates because these are meds I need right now to save this child's life. So for example, laryngoscope blade for a small child, yellow, would be a 2. A tracheal tube size of 4.5. It's going to even mention nasogastric tube, urinary catheter, chest tube. It's literally giving us everything. These will also have seizure medications. These are going to have any med that you would give in a resuscitation is going to be on this. And so that's why this is so important. Now, eventually you'll get a weight-based, everything. You'll get the weight of the patient. If you have a little bit more time, let's say you have a decompensating asthmatic that's coming in through the front door, they are struggling, you're given all these different meds, you're able to get a weight. The nurse is actually able to print off a code sheet for you, and on that sheet it's going to have a list of all the medications that we give. In this particular case, the child roughly, we're going to say, is 25 kilos or 55 pounds. When we correspond that to the actual chart itself, again, if we track it back, that would put the child roughly orange in terms of the weight itself. Now, obviously, things can change. And so when we look at the medications and what they can administer, the size ET tube they put in was a little bit interesting because based on that, the ET tube size was roughly around yellow. So the fact that, the kiddo didn't get a 5.5 or a 6 tells me, okay, maybe it was an airway issue. Maybe they tried a larger ET tube size, they couldn't get it, and they moved down to a smaller one. That I don't know, but again, it's technicalities, but overall a great scene. They're following the Pediatric Advanced Support guidelines here, which is why they're given a weight-based epinephrine. So again, just a little bit of intro, at least, into the Braslo tape.
We're going to take over compressions. Any family coming in? Grandma and little sister.
Fast and deep.
So I just paused here, and I've been doing this throughout this entire season. Anytime there is a Princess CPR going on when it's not being done correctly, especially for people that are tuning in for the very first time to my channel and are like, why didn't he comment on the CPR? Compared to, other individuals that are like, Dr. Taylor, you keep talking about the bad CPR. We get it already, right? I've had a few comments. They're like, Dr. Taylor, just stop already. We get the bad CPR. Again, I'm going to point it out every time. And so in this case, though, I don't want to focus on it too much. We're not going to talk about, how to do it correctly and all of that. It's been in previous episodes. I really here want to focus on the patient just because of how sad this case already is. So again, feel free to take a look at episode 1 and episode 2 where I went into detail on CPR.
Ready?
She's really cold.
Okay, yeah, get a cord tip.
Big breath sounds bilaterally.
Now, when this patient arrives, we want to confirm our own endotracheal tube placement. Yes, EMS intubated the patient prior to arrival, but we still want to confirm ourselves on arrival to the ER by listening to breath sounds. We want to make sure that we have bilateral breath sounds. It doesn't matter if you're a kid, it doesn't matter if you're an adult, we confirm this every single time. Now, obviously in the filming, you take an ET tube, you cut it in half, and you put it in someone's mouth, it looks like they've been intubated, right? But again, we're stating what's realistic and what's not. So this scene with how much is, left out of the mouth, this looks correct, this is spot on. Overall, this scene looks very realistic. And now Dr. King is actually listening to bilateral breath sounds and confirming. High praise. I love this. I did not expect this to happen. Somehow, I don't know what I was expecting. Somehow to throw an ultrasound on it and someone say something. I don't know. I was going to be confused.
Should we use the Lucas? No, she's way too small for that.
So Whitaker had a great suggestion here. He said, can we use the Lucas? Now, the Lucas is typically used in adult patients and those greater than 12 years of age. Key thing, that fit the device. It's actually contraindicated in patients less than 12 years of age. But overall, great suggestion, and it's a great teaching case.
Rectal temp only 85.
What do you think, Mel?
She's cold, moderate hypothermia.
Now, the rectal temp is 85 Fahrenheit. Now, this patient is hypothermic and needs warmed. Dr. King states moderate hypothermia here. That's exactly right. Mild hypothermia is 90 to 95, moderate 82 to 90, severe 68 to 82, and profound hypothermia less than 68 degrees. So now in this critique, I'm going to mention both Fahrenheit and Celsius. I know sometimes it can be confusing. A lot of times in the medical literature, we see Celsius all the time, and then mentally you have to kind of convert that to Fahrenheit to be like, oh, that's what it is. So I'm going to try to put both at least on the screen for you.
We need to get her up to 90 if we have any chance of restarting her heart.
250 cc's heated saline. Set up the Arctic Sun, continuous core temp monitoring, and prep another epi 0.25.
Yep.
So Dr. Robbie states we need to get her temp up to 90 if we have any chance to restart the heart. So you may say, Dr. Taylor, what does that mean? What do we do? So according to the Annals of Emergency Medicine, victims of cold water near drowning have been well documented to survive prolonged up to 66 minutes cold water submersion with little or no neurologic deficits. In these cases, the length of effective anoxia is often much longer than that usually required to produce irreversible neurologic damage. So that is because of the protection of the brain that is commonly attributed to low rectal temps, which provide a neurologic protection by lowering that cerebral metabolic requirement for oxygen, and of course the dive reflex, which is presumed to optimize the delivery of limited oxygen stores to the brain. So the article goes on to state that the majority of intact survivors are children. Children are thought to have a survival advantage over adults. Now, children have a greater surface area to body mass ratio and therefore are believed to cool fast in cold water. It's also thought that the dive reflex is preserved to a greater extent in children. So we know that residents are 3 months into their residency. So you generally start July 1st. So likely they completed, the month of July, the month of August. And then what I can't quite tell is this the 3rd month in the residency, or have they completed 3 and then they started the 4th month? Either way, we're probably around September, give or take. So pool temps could be a little bit lower. Now, recovery from prolonged cold water submersion is well documented. Things that we look at though, is it wintertime, for example, and the water is freezing? Or is this summertime and the water is 60, 70 degrees, somewhere in there? Much different. How long was the initial person in the water for, right? Were they in there for an hour, 2 hours? How long were they in there for? What was the initial rhythm when EMS arrived on scene? So in this case, with this particular patient, it was asystole. What is the initial rectal temperature of the patient? Is the patient a child or an adult? These are things that we're looking at. So an article published in the British Medical Journal entitled Outcome After Resuscitation Beyond 30 Minutes in Drowned Children with Cardiac Arrest and Hypothermia. It's a Dutch nationwide and retrospective cohort study. They state cardiac arrest in children that drown is often associated with hypothermia. In such children, guidelines advocate continuation of resuscitation beyond 30 minutes. The rationale here is that hypothermia is potentially reversible cause of cardiac arrest, and that hypothermia could exert a protective effect on the brain, kind of what we talked about, by slowing its metabolism. The current practice is to continue resuscitation until the core body temperature is at least 32 Celsius, until that's been achieved, which is equivalent to 89.6 or 90 degrees Fahrenheit that Dr. Robbie mentioned, so spot on. We need active rewarming here, rather that be warm saline, warm blankets, bear hugger, etc. Plenty of options that we can do, and we're not going to go into all of those. But the phrase you may hear often is, you're not dead till you're warm and dead. That's what this is based on. Now, I will say the caveat to that is, unless you are really, really, really dead, right? Then there's no amount of rewarming that's going to happen. So we're going to talk more about that in just a minute.
Preemptive order's done. Let's go.
I don't understand why you need me.
Crohn's disease status post-colectomy 10 years ago now with severe abdominal pain. Could be perforation, fistula, obstruction. Great teaching case.
So to recap, this is a patient with Crohn's disease, a chronic inflammatory bowel condition. Now this patient is status post-colectomy 10 years ago and now with severe abdominal pain. Now Crohn's can affect a lot of different things. Now in terms of just the intestines, just talking about just the intestines, most commonly it's a small intestine. But in this patient, it must have affected the first part of the large intestine because she ended up having a colectomy. Likely this was a partial colectomy, so part of the large intestine was taken out. We also hear that this is a kind of a high maintenance surgical patient. So basically this is probably a patient that's had, a lot of chronic abdominal pain, a lot of surgery follow-ups, potential multiple surgeries, well known to the ER. These are typically patients that, when they come in, the surgeon's actually notified right away, hey, we have your office patient coming in. They know the patient well, right? They know what meds work. They know everything about that patient. So this is spot on accurate.
Someone give me something for the pain!
Good afternoon, Ms. Walker. I'm Dr. Garcia from surgery. This is Dr. Santos and Javadi. It's like you're in a lot of pain.
No shit!
We ordered you some morphine.
Did you read my chart? I'm allergic to morphine. I'll puke my guts out.
That's a side effect, not an allergy.
Give me some Dilaudid.
Okay, 1 milligram Dilaudid.
I'll grab it from the PDS.
It is never enough. I need 2, sometimes 4.
Got it. Pertinent history, Javadi.
Have you had any fever or vomiting? Oh, shut up with your questions.
Man, we can't help you.
If you want to help me, give me my doctor. Dr. Shamsi. 10 years, no one knows me better. I don't want to talk to anybody else.
I'm very sorry, but she's in surgery right now.
How long?
Unknown.
Oh.
But ma'am, right here, we have Dr. Shamsi's daughter, Victoria. She's the next best thing.
Now, when a patient comes into the ER, what's interesting about this scene is we can really kind of go a couple different ways. When you have a high maintenance, for example, surgical patient, or you could just say, a patient that's well known to the surgery clinic that's coming in, the surgery team's probably already aware only because either they called the office or something. So they're aware and they're probably on their way down. But it has to do, this next part has to do with kind of how we function in the ER. When a patient comes into the ER, they're typically seen by the ER attending first or an ER resident, and then it's staffed with the attending. If a surgery consult is needed, we're then calling surgery once we have assessed that patient. Now, kind of getting back to this case, if a surgeon knows that their own patient's coming into the ER, they sometimes will actually see the patient before the ER provider does. But the ER provider has to still see that patient and dispo that patient. Rather, this is an admission, this is a discharge. Just last night, I had a patient with a VP shunt malfunction that was in the waiting room for 7 hours. Neurosurgery sent that patient in. Neurosurgery actually went to the waiting room, took the patient aside, did their full exam, actually boarded them for the OR, and then the patient just needed an ER doctor. They finally got a room. I went in there, did my exam, ordered some blood work, got them admitted to the hospitalist, right? The ER doctor is still doing a physical exam, you're still doing the blood work, you're still seeing that patient. You're then placed in that admission order. So when a patient comes to the ER, regardless of the specialist seeing that patient, they have to have an ER doctor see that patient. So in this particular case, there was no ER attending at all seeing this patient. This is the surgery resident that recruited some of the ER residents for teaching. That part, recruiting for teaching, that's fine. If they want to learn and, you have the ability to take them out of a case to bring them in another one, that's totally fine. But maybe the ER attending will see this patient later. But this cannot just be general surgery seeing this patient. It does have to be seen by an ER attending, or at a minimum by one of the residents, and then staffed with an ER attending. So that was the part of this case that quite wasn't making sense and wasn't quite realistic, is not having an ER attending at least be aware of this patient.
Time for another epi.
Dr. Robbie.
Be right back.
My wife and I decided we're on board with organ donation.
Oh, I'm really glad to hear it. The church supports their decision.
The OPO is sending an ambulance.
I'll be staying with the family.
How's it going in there?
Oh, not good.
Robbie, for the little girl in trauma 1, this is grandmother Frances and sister Bella.
Hi, I'm Dr. Rabinovich.
How is she?
Bella, would you like to color? Maybe get a snack?
Yes, please.
My name's Kiara. Let's find you some crayons.
I like to draw.
Let's do it. Come on.
So this episode is just getting me. This is the sister of the patient, and her name is Bella. Cases like this give me bad PTSD. In one of the episodes, I spoke about a child I had in residency. Family was moving, very nice family. A large dining table was leaning against the wall. The child ran into it, and the table fell, crushing the skull, and the child came in, CPR in progress. At the time, that child was the exact age as my daughter. Her name is Bella. It's one thing to take care of kids when you have no kids, but the moment the child that you're taking care of is the same age as your child, it's going to affect you differently. It's going to be harder to compartmentalize. It's harder to not think about it. In my case, afterwards, we had a debrief. We all talked about it. All the staff talked about it. I went into the restroom for 5 minutes and cried. When I got home, I just hugged my daughter Bella. Didn't tell her why, didn't tell her what happened, but I just hugged her for a long time. It's been 6 years now, and I still think about that case all the time.
They are still doing CPR.
Can I please see her?
Yes, of course. Got Grandma coming in. You sit right by the bedside.
You ready to switch?
Go.
So I'm a firm believer in having family in the room to witness everything. When we're talking with kind of family before they go into the room, I'll tell them, they'll know what's going on, and I'll make sure they're okay with it. But I do encourage them to at least be a part of it and to witness what's going on. Sometimes I think it brings closure as well for the family to see that the entire ER team is doing everything in their power to try to save this patient and bring them back to life. And so for them to stay in the room and not go in, again, I think it's going to be a little bit different. Yes, it would be extremely hard watching, your son or your daughter get CPR. But when you're there bedside while they still, while they're getting CPR, you're able to talk with the attending. You're being able to see the ER team doing all of these different things, procedures, meds. It's going on and on and on. As a family member, as a husband, a wife, as a father, a mother, you're seeing all this. And you know that this team is doing everything without question. You're not questioning it later. You can see them doing all this. I think it brings closure. And again, I'm a very firm believer in having the family be able to witness something like this.
You can hold her hand. She wasn't breathing, so the medics put a tube in her throat.
She's so cold.
We're warming her up. That way she'll have a better chance to respond to the medicines.
They moved a bench next to the pool fence so they could go over. Because their soccer ball went in the water. Amber couldn't make it out the deep end. The gate was locked. I was vacuuming. I didn't hear them.
So the basic sequence of events in drowning that leads to death: water is going to enter that mouth, obviously, when no longer able to keep it clear. Initially, the water is going to be spat out or swallowed. The conscious response at this time is to hold your breath. At around that 1 minute mark, obviously some shorter, some longer, even up to 2 minute mark, the respiratory drive is just too high to resist. At this point, either laryngospasm is going to occur or just continued aspiration of water into the lungs. That leads to hypoxia, loss of consciousness, and apnea. So the aspirated fluid then, that water, leads to surfactant washout and dysfunction, increased permeability of the alveolar capillary membrane, decreased lung compliance and ventilation perfusion ratio mismatch. This can result from minor to no respiratory complaints to fulminant non-cardiogenic pulmonary edema with clinical pictures similar to acute respiratory distress syndrome known as ARDS. So within 4 to 6 minutes, we start to develop irreversible brain injury. Global CNS hypoperfusion induces the release of excitotoxic neurotransmitters, free radicals, lipid peroxidation. Cerebral edema followed by autonomic instability often results, followed by ST segment changes indicating stress-related myocardial damage. The hypoxemia also induces ventricular arrhythmias and severe pulmonary hypertension. The final mode of death involves cardiac dysrhythmia. So that's your tachycardia to bradycardia to pulseless electrical activity, finally asystole. That whole drowning process from submersion or immersion to cardiac arrest usually occurs in seconds to a few minutes. However, the key thing here is that up to greater than an hour in unusual cases of hypothermia. Again, those are kind of different cases where they fall through the ice. Again, some of the things that we mentioned about before, but greater than an hour in unusual cases of hypothermia. But in this case, overall, that final mode of death can happen between seconds to just minutes.
How is he doing?
Stable. Scheduled for a new pacer tomorrow with cardiology.
Great.
Perfect. So they spoke with cardiology and he's scheduled to get a pacemaker the next day. So the temporary transvenous pacemaker will come out and the implanted pacemaker is going to be placed.
Robin, parents at T1. This is Dr. Robin. Where's Amber? Is she okay?
What have you heard?
She got pulled from the pool.
She wasn't breathing, so we're doing that for her now, and we're trying to get her heart started again.
Wait, her heart stopped?
I have to be with her.
Of course. There are a lot of people in here right now trying to help her.
I understand.
So here he asks, what have you heard? That is perfect. I do this every single time when I have a cardiac arrest. You want to establish what the family knows already so you have a baseline for the rest of the details. Let's say it's a different situation. You heard that your loved one was sick, but you had no idea, because you heard it from somebody else, you had no idea that the patient was actually getting CPR or something. So this could be, for example, you get 80-year-old grandpa, family only knew that he was sick, not that the nursing home called because he had no pulse, and you see him, CPR is actually in progress, you're talking with the family, and you immediately start with that you're doing CPR. They're going to be like, what are you talking about? The nursing home just told us that he was sick and going to the hospital, not that, he was getting CPR en route or anything like that. So I try to establish what the family already knows, and then you use that as a basis to kind of explain the rest of the situation. All right, so just like every episode, I try to have some comments that I received from the previous few episodes. So we're just going to go through a few of these. All right. My wife recently had a miscarriage and works in the NICU, so neonatal ICU. I am forever grateful and thoughtful of our hardworking medical professionals and what they do every day. Thank you for reminding us that our medical professionals work hard to provide the best care even in the hardest personal times. So thank you, I appreciate that. This is one of the few series I'm always willing to drop everything and watch. I might not know what 90% of what's going on or said in each scene, but you and Dr. Mike, to an extent, are the few experts that I love hearing a breakdown each of the important scenes. I really can't wait for each new episode review coming out because I know it'll be good. So thank you, I appreciate that. What Dr. Mike does is absolutely awesome. So Family Doc, awesome doc. I watch all his stuff on YouTube, big fan. I'd love to collaborate if he's ever looking to work with an ER doc from Indiana. So definitely reach out and I'm game. Next one. Hi Doc, I know I'm highly motivated watching this series to get trained in CPR and basic first aid, and I think a lot of your viewers would be as well. Your platform might be a great way to recommend specific organizations, courses to get trained. Thank you, and I vote for the long form content. So this one's really getting at the fact that this is a brand new channel. This is only 2 to 3 months old tops, and the majority of this channel are medical professionals, lots of techs and nurses and doctors, attending surgeons, literally everybody, and obviously plenty of non-medical as well. Initially, early on, I'm like, do I do shorter videos? Do I do longer videos? And YouTube, the viewing hours, my average watch time with all these videos is crazy long at nearly 30 minutes now. So people are just watching the long format videos, so I appreciate that. This is just a reminder that the ER is the place where imagination is out of the window when it comes to foreign objects and certain cavities. While slipping on something, accidentally. So they're actually referring to the video I just released on rectal foreign bodies, vaginal foreign bodies. And so that's a new segment. I'll be putting out part 2 probably within the next couple weeks. But those are actual x-rays. Those are actual foreign bodies that people found at Target specifically. So feel free to check that out. That is not a short. That is underneath the long format videos. Next one, I don't think anything could horrify me more than the phrase anal splinters, but you managed to outdo it with the ostomy story. So this is referring to people that place foreign objects inside their ostomy and they get lodged in there. Again, this could be knives and spoons and forks and objects and toys and cars, anything in that ostomy. First off, nothing goes in the ostomy. It shouldn't go in the ostomy. And so again, that's referring to that foreign body video that I put out. All right, so next one, not in the medical field, but I love to stay informed, and you're my favorite channel to watch. So much learning with it and still being entertaining. Good job. So thank you. I appreciate that. I know the channel is in depth. I am taking a deep dive into each episode. I'm going to do that for every season of the PITT, every episode of the PITT that comes out. And then we're also going to be looking at some new things as well. So sometime in the next few weeks, I'm actually going to be filming a live reaction to at least the first episode of The Resident. We're probably going to get a few of those in there. I'm actually having my buddy just kind of show me, give me all the scenes that he thinks I'm going to react differently to. And those are the ones that we're going to be pausing on. So I'm super excited about that. And so we're going to do a live reaction on The Resident. And so we'll see how that goes. Next one. Excellent review, as always, and great explaining the procedures as well. As a former organ recovery specialist, this show felt like being at work again. But Doc, spot on, hands down, the best review and the most detailed reviews on this show on YouTube currently. Again, I thank you, and I really appreciate that. Again, we're going on episode 8. I'm going to be hitting 9, 10. We're going to go all the way to 15. And so we're going to keep at it. We're going to keep going in the level of detail that I'm going into. And then we're going to start doing that for a few other TV shows as well. And for those interested, I also have a YouTube monthly membership option, so feel free to check that out. The link is in the description. Plenty of benefits, including early access to videos, live chats with myself, in addition to expert medical answers to questions. And if you're a med student, future resident, you got questions about your application, the interview process, what to do, what not to do. If you want me to edit, your personal statement, take a look at it. I will pick it apart. I know what they look for. I've been on those committees. I'm here to help you out. So again, feel free to take a look at that membership, and let's get back to the critique.
Amber. Oh my God, Amber. I love you. I love you so much. I am so sorry. Where's Bella?
She's with our social worker.
Oh, I should be with her.
I'll go with you, Mom. I'll be right back.
Okay, come on, she's still in the hall a bit. Hang on, we got it.
Oh.
Rhythm check, hold compressions. Asystole, resume compressions.
3 minutes since the last epi.
Push another.
Did you shock the heart?
No.
Why didn't you shock the heart? We've got to say, you got to shock the heart.
Heart rhythm right now is flatline, and that's not treatable with a shock. We're trying to get the rhythm to change to something we can shock by warming her up.
Okay, so we got to warm up. We got to get some more blankets in here or something.
Giving her warm IV fluids, and you can feel these blue pads. They have warm water running through them like a hot tub.
Are you sure you're doing everything?
Yes, we are.
Amber, honey, I'm here. It's gonna be okay, I promise you. Everything's gonna be okay.
I just love everything Dr. Robbie is doing. He is maintaining composure. He's stating to the mom what they are doing, why they are doing it. He is literally explaining everything and addressing things to make sure the mom is aware that the ER team is doing everything in their power to try to bring this patient back to life. I almost got teary-eyed just watching this scene. I just need to take a pause here. Overall, this is just too realistic. I think this whole scene is very difficult. It's difficult to talk about. It's difficult to teach, to educate my audience about it, just because of how realistic this is. Again, I don't know the case that was behind this case, what inspired, the physician to write this particular part of the episode. but clearly it was a very difficult story because, just the writing just makes this come to life when you see it. And when I'm trying to teach it, trying to, critique everything and take it step by step. And then I keep thinking in the back of my mind of that case, 6 years ago of the open skull fracture CPR. So overall, again, a very realistic scene. Everything about this scene so far from an emergent standpoint is just spot on.
I can't take it much longer.
Dr. Shamsi on speakerphone from the OR.
Eileen, how soon can you get here?
I'm finishing a lap coli. Shouldn't be long.
Your daughter's here.
Hi, honey.
Minimal relief with 2 of Dilaudid.
She needs 4.
That's what I've been telling them.
We're titrating. We didn't want her to stop breathing.
Is Dr. Garcia with you?
Right here.
How's the exam?
Rigidity with guarding.
Sounds like peritonitis. 2 sets of blood cultures and 3.375 of Zosyn. Make sure she's next in line for a CT scan. Bump everyone else. Do you understand? Victoria?
Got it.
See you soon.
Thank you, Eileen.
Ready for some more Dilaudid?
God, yes.
Victoria will make sure all of Dr. Shumsey's orders are followed. Call if you need us.
Yeah.
Great move bringing in Javadi. Is this patient payback for dropping the scalpel? Look at the bright side. If she goes to the OR for perf and you can scrub in, I'll coach you. You'll make a brilliant first impression on Dr. Shumsey. Really? You do that? Mm-hmm. Thanks.
I see, what they're doing in this scene. It's the surgeon's patient, but still an ER attending would be seeing this patient first. And if not seeing it first, they would be in, shortly thereafter because maybe the surgery or the surgeon just got in there first. That happens sometimes. You walk in to see a patient and the specialist is actually already in there because they were aware that patient was coming in. So again, maybe given the benefit of the doubt, maybe that's what's going on. They're just so busy. Patient's roomed, the ER attending will be coming in next. I'm gonna give the benefit of the doubt here that the ER attending has just not been in that room yet, all right? The surgeon is assuming without seeing the patient, right, over the phone, that she needs 4 milligrams of Dilaudid because likely every time that patient has presented with abdominal pain before, the patient's required 4 milligrams of Dilaudid. Now, I will say, this patient is likely used to having higher doses of Dilaudid, which is why 2 to 4 milligrams is not enough, to make her go apneic. If I got that much, I would need Narcan, I'd probably be intubated. But for the surgeon to say she needs 4 milligrams without seeing that patient's pretty messed up, right? We hear no mention of any blood pressure. Let's say that patient was, in this case, we know that they're not, but let's say that blood pressure was 90 systolic and you give 4 milligrams, they're gonna go hypotensive, they're probably gonna pass out. It's gonna have a great effect on the blood pressure itself. So again, no mention of any vitals in here. The surgeon says she is next for CT scan and to bump everyone else. No, and that's not realistic. You can't do that. One, you're not in the ER. This is a phone call. You're not seeing the patients. You're not seeing the other patients. You have no idea the acuity of the other patients. We also don't know how many CT scanners are even available. Some ERs have 1 CAT scanner. Some have 2 CAT scanners, right? Maybe even more than that. If I have a patient that needs a CAT scan faster, let's say someone comes in, I'm very concerned about them, and I need them next in CAT scan, but I know there's like 5 or 6 others that are ahead of them, but I'm concerned about something, like an aortic dissection, for example, right? Aortic dissection here, I need that patient in CAT scan, but I know they're further down that list. I'm just gonna check with my other colleagues, be like, hey man, this is what I got. I need this patient in CAT scan. Are you cool? Oh yeah, go right ahead. Give a call to the CT technologist. Hey, can this patient come first? Or can this patient come next? So there's a few phone calls that you're making. So overall for the surgeon, to say, let's bump the patient next in CAT scan, that's not how this works. And so that part was just not realistic. Or is it realistic because whatever this case was based on, that surgeon happened to actually say that? I don't know. But just because the surgeon says to bump everyone does not mean that that happens. And I see this often. I see this quite a few times. That's just not how it works, right? You got 80 patients in your ER and you don't know, as the surgeon, you don't know which one of these patients is higher acuity. You don't know where that CT list is. And all of a sudden you're saying, let's bump everybody and I want this one next. Sorry, that's not how that works. Maybe vascular wants a CT angio of the abdomen, it's an ischemic bowel. Maybe you're dealing with a aortic dissection, right? You're not just gonna get bumped. So there's gonna be a little bit of a wait list there. But overall, that was the part of the scene that quite wasn't realistic, but I just want to kind of clarify just a few things for the audience.
Kind of a weird vibe out here.
Yeah, pediatric drowning will do that. Glad I didn't end up in there. Yeah, you and me both. What's with this scarf? Oh, it's from the Lost and Found from my patient in Central 8. Cool. I'm off to North 2, to see Uriah. What happened to 2 visitors a patient? It's the fentanyl overdose. It's gonna be an honor walk. He's an organ donor. I'll see you later. See you. Myrna? Myrna. Oh, no, not today. Myrna! What the fuck? What do you think you're doing? I was just checking on you, ma'am.
You can't even take a nap in this hellhole. Fuck off.
Sorry.
I cannot tell you how many times I have done this exact same thing. The patient is in some deep sleep coma, right? Maybe they even have underlying obstructive sleep apnea. They've been awake all night, various other risk factors. And they were so far out of it that you would swear they were in cardiac arrest. And you wake them up and they are pissed, right? You sternal rub them, they're still not waking up. Eventually they do, and they just get mad and start yelling and swearing at you. So overall, this is very realistic. This happens.
Any change with the extra dilaudid?
Not really. The pain is still there.
Sorry. Sorry, just to review, no fever, no vomiting, no diarrhea, no constipation.
Correct.
When exactly did the pain start?
10:15 this morning, all of a sudden.
That's very strange.
I agree.
Will you tell me everything you did this morning?
Took a shower, had breakfast, some coffee, toast with jam, yard work, moved some firewood.
Did the pain start before or after the firewood?
A little bit after.
So she's asking some legit questions here. To have this rigid of an abdomen where you're questioning peritonitis, an intra-abdominal infection, this bad intra-abdominal catastrophe that needs the operating room, yet you have no fever. Granted, this is early, it was more of an acute onset, so you may not manifest some of the lab abnormalities, but let's say, there's no fever, there's no vomiting, there's no lactic acidosis, there's no white count, there's no left shift, there's no bandemia. All of these things are normal in a patient of this age, acute onset, just like that. It should make you think, okay, could this be something else? And obviously, that's what they were going with this scene, right? She started taking this detailed history. I love this for a med student to ask these, these questions, to recognize, hey, this doesn't seem normal. This doesn't seem right. Maybe something else is going on. I love this. These are very, small details, but as an ER attending, when we hear a med student ask, this level of detail, we're like, maybe she's interested in emergency medicine, but that's such a very specific question, that she's asking in terms of the wood around, the logs around, is this a fire pit, moving wood? What is the nature of where she was that day? In the case of a Black Widow, again, I'm gonna put some stuff on the screen for you to kind of talk about at least their environment and what to expect with that. So again, mad props with this scene. The med student was terrific in this scene.
I might have got a splinter in my foot. I wasn't wearing socks. Other one.
Two small puncture wounds, 1 millimeter apart.
2 splinters.
Whoa.
What?
There's a dead Black Widow spider in your shoe.
You're shitting me.
Red hourglass marking.
So I'm always super excited to talk about the Black Widow spider bite. Now, it was only a matter of time before we were introduced to the Black Widow spider bite. Personally, I was hoping for the brown recluse spider bite, but I'll take the black widow spider bite. So a black widow spider bite is literally a pinprick. You'd swear you just like stepped on a needle. So it's just a local pain. The redness or erythema appears typically within 20 to 60 minutes. And some patients may have a little halo, some will have a little targetoid shaped lesion. So if you look at the bite mark in this episode, that is exactly what you see. Spot on. Love it. One of the board questions that emergency medicine residents may get asked is a patient that was working in the yard, they were moving firewood, and they literally had a pinprick sensation. Now they have generalized pain, severe abdominal pain. And the reason they have severe abdominal pain is secondary to muscle cramps of the abdominal wall. So that abdominal wall musculature literally just contracts, and they have such a rigid abdomen that you're like, something bad happened here. And sometimes it can actually be very difficult to differentiate this from peritonitis. So generally treatment is local wound care. It's analgesics, it's tetanus prophylaxis, it's opiates, it's benzos. Ativan works very well in these patients, and that's typically my go-to for these situations. So I love this.
We need IV diazepam. Start with 5, might need 10.
What does a spider bite have to do with my Crohn's disease?
Oh, nothing. Black widow venom can cause muscle spasms in the belly. People have had surgery thinking it was appendicitis.
So I just wanted to say this here because we keep seeing this over and over and over again. Medical students cannot give orders. I repeat, cannot give orders. Now, the medical student can place an order, right? They can go to the computer and they can place an order, but that resident or attending signs off on this. They can't actually submit that order. When a med student puts an order in, all right, it's gonna go to either the resident or the attending's box. And so they're assigning it to them. So this medication is not given till either the resident signs off on it or the attending signs off. In the case of, a nurse taking a verbal order, all right, in this case, the med student had stated to the nurse, what med, they want given. If a nurse takes a verbal order, so they go to the computer, the verbal order, they can't actually assign, they can't have a med student in there. It doesn't even give you that option, right? It's a resident or attending. So the nurse would have to put either a resident or an attending. I can already tell you this, a ER nurse, I'm gonna say this again, an ER nurse is not going to take an order from a med student as a verbal order in the computer system and add a resident or attending to sign off on that. That's just not gonna happen. This is 100% not realistic. We see this every now and then. Actually, Chicago Med actually had a scene of this where one of the med students actually gave a verbal order to one of the ER nurses. The ER nurse administered that medication, and then one of the psychiatrists actually said, "Who gave this medication or who ordered it?" And he states that the med student states he ordered it. He can't order it. You can't do that. And so in this case, again, it has to have an attending or a resident. So she mentions diazepam, which is fine. It's a benzo. It's terrific. Diazepam, whatever benzo you want to give is totally fine. I have a preference for Ativan in these situations, but diazepam is fine. She would need to either staff this case with the ER resident or attending, or talk with the surgery resident and have the surgery resident sign off on this. I've seen this quite a few times over and over again. So I just wanted to pause here because this is 100% not realistic. A nurse administering this medication after a med student either gave a verbal or stated they ordered it, because med students can't do that.
Hi, Dolores. Why didn't you get her to CT yet?
I don't think she needs it.
The abdomen is rigid. She's perfed.
Maybe not.
What are you giving?
Diazepam.
I didn't order that.
I did. She has a rigid abdomen, but no other GI signs or symptoms. It didn't make any sense. There's a black widow spider and a bite mark on the foot. The venom is causing spasm of the abdominal wall musculature.
Whatever you guys gave me, it's working.
Possibly.
No, definitely. I'm much better.
So this is a great medical student, but medical students in this situation cannot just place an order and then that order is given. Seriously, come on, writers, you know this. The ER physicians behind the scenes know this. This makes zero sense. She's brilliant. Awesome medical student. If I was running a residency program, this was real life, she was interested in emergency medicine, yeah, this would be awesome. We would love to take this med student, but she cannot sign off on the administration, all right? 0 medications is what she can actually sign off on. This is one of the reasons why these cases are staffed with someone. If I have a medical student seeing a case with me, as an example, they see the patient, they can actually place orders in the computer. CBC, CMP, they can put in there, all right, 4 of Zofran, 15 Tor, they put all these in there, all right? They submit those. Those don't go to the nurse, or those don't have the ability to be given by a physician. Those actually get sent to either the ER resident, or they get sent to the attending to sign off on those. That's how that works. And so those orders just kind of float in the cloud until somebody signs them. But the common thing we see in TV medical dramas is a med student reportedly orders something, gives a verbal order, the ER nurse, which no ER nurse is going to do this, but take the verbal order from the med student without the resident, without the attending knowing. No ER nurse is going to do that, right? And so in this case, it's just not realistic. Nurses do not see anything until that individual has, either the resident or the attending has signed off on the medications or orders, which is why sometimes, again, it's actually much easier for the resident or attending to just order everything ourselves. We'll have a med student, just saw the patient, and then they staff the case with me, tell me about it, give me the whole, H&P, give me the review of systems, a physical exam, give me their differential, what they want to do, and they'll list, let's say 15 lab tests they want to do. Sometimes it's much easier for me just to put those in like 10 seconds and hit sign for the labs that I want ordered, versus they put them all in, then I have to review them, then I have to sign them, then they're sent to the nurse to actually get done. So overall, this scene is 100% not realistic.
Core temp is 88.
Is that good?
It's up from 85 on her arrival, so we're headed in the right direction.
You hear that, Amber? It's better. You're getting better.
I need to step out for a second. You're in good hands. Come find me when it's over 90.
So Dr. Robbie states, come find me when it's over 90 Fahrenheit or 32 Celsius. This is the concept we spoke about earlier, that you're not dead till you're warm and dead, referencing that 90 Fahrenheit cutoff. The key thing is that cardiac drugs and defibrillation are usually not effective in the presence of acidosis, hypoxia, in the hypothermic setting. So you want to make sure that you're doing everything you can to increase that temperature. You would not want someone to be hypothermic and asystole, and you call it, for example, after the patient was found under ice water, versus you warm them up and you get a heartbeat back. So this situation is a little bit different, as you didn't just have hypothermia from being in, like an ice water, but you also had that drowning in hypothermia aspect of it sometime around, September. So you really have two things going on here at one time. Again, a little bit different than wintertime, walking on the ice and fall through the ice.
Parents are gonna need the family room.
It's available now. Last ride's for Nick.
Just one of those days.
Yeah,
Anyone else dying?
not at the moment.
What the hell is that?
Who asked for better patient satisfaction scores? What do you want, man?
Excuse me, Dr. Robbie. This is Eli, son of Willie Alexander.
Hey, nice to meet you.
Likewise. How's he doing?
He's doing better. He's gonna need to stay with us, though, for a new pacemaker.
He got a new one at Presby about a year ago. They said it'd be good for 10 years.
Yes, but the wire's separated from the box. It happens sometimes.
Can he have a visitor?
Of course, right this way.
Hey, Eli, what did your dad do for a living?
Postal worker, 40 years.
Did he ever do any volunteer work at the hospital?
No, but when he was a kid, he was a medic for the Freedom House Ambulance Service.
That's incredible. I will be in as soon as I can.
Thank you.
Guy's a legend.
I know.
So here we actually find out why the individual with bradycardia knew so many medical terms and seemed like he worked in the medical field. And it turns out he was part of the Freedom House Ambulance Service. So for this, I turned to Team Rubicon. This is a humanitarian aid organization, as they spoke about the Freedom House Ambulance Service on their website. So I'm going to put this quote on the screen for you. They state, In celebration of Black History Month, Team Rubicon is sharing the stories of Black trailblazers in our line of work, emergency management and disaster response. One group whose work has had a profound impact on the world's emergency medicine service systems is the trailblazing Freedom House Ambulance Service. Founded in 1967 by the Pittsburgh civil rights organization Freedom House, which offered job training and assistance to Black Pittsburghers, the Freedom House Ambulance Service was created largely to serve the predominantly Black community of the Hill District. The article goes on to state, founded in a predominantly Black neighborhood and staffed entirely by Black paramedics, the Freedom House Ambulance Service set the standard, that is awesome, set the standard for ambulance service and helped establish the training program and procedures for modern EMS systems. They went on to say, help the develop the first national training standards for paramedics and the first nationally recognized design for ambulances, making EMS history. I absolutely love this.
It looks like ST elevation. That could be bad.
Oh, no, that's just because we're pacing your right ventricle. Willie, I'm impressed. After all these years, you still remember your medical training.
Well, he couldn't tell you what he had for breakfast.
It's all right. I remember what's important, like the Freedom House.
What's that?
Damn shame. That's your history.
Dad, they're busy.
Back in the 60s, no 911, no ambulances. All we had was police paddy wagons that took you to the hospital if you were lucky. Then this doc from PITT, Dr. Safa, he got some money and trained us up.
Well, you must have been a good student.
Hell no. I was a knucklehead. Smoked a lot of weed, dropped out of high school. But Freedom House trained me up. Saved my life.
What are you doing there, Willie?
Nothing.
You're moving your old pacemaker.
Diagnosis made.
What?
Twiddler syndrome. Spinning that thing around caused the wires to break off.
Dad.
I didn't mean to.
That's okay. We'll put the new one in a little deeper. Won't happen again.
Diagnosis made. If you recall earlier, his pacemaker wires had come apart and this was a relatively new pacemaker. This is Twiddler syndrome. For anyone interested, I will post a link to an article published in the Journal of the American Osteopathic Association entitled Pacemaker Twiddler Syndrome by one of my colleagues and a fellow Air Force doc that did pass away a few years ago, but has a terrific article entitled Twiddler syndrome. So basically it's caused by spontaneous, inadvertent, or deliberate manipulation of implantable devices resulting in lead dislodgement and permanent malfunction of the device. So retraction of the electrodes actually may cause phrenic nerve stimulation, resulting in diaphragmatic stimulation and a sensation of abdominal pulsations. So implantable cardioverter defibrillator, spinal cord stimulators, and chemotherapy infusion pumps have been involved in cases of Twiddler syndrome. Most cases are diagnosed within the first year of device implantation. Elderly and obese patients may be at an increased risk for Twiddler syndrome because of the loose subcutaneous tissue, which allows for easier rotation.
Temp is up to 91. She's so much warmer. It's working.
Can you shock the heart now?
91 is warm enough for her heart to respond.
Hold compressions. Asystole.
Resuming compressions. Got the potassium level back, 12.2.
So in general, there are multiple things to consider when deciding to call time of death in this situation. Poor outcome in this setting has been associated with asystole, CPR greater than 25 minutes, dilated non-reactive pupils, pH less than 7, and lactic acidosis. So termination of CPR should be considered if the potassium is greater than 12 and asystole persists despite rewarming the patient to 32 Celsius or 90 degrees. I will say that lactate and pH do have less consistent prognostic significance within the literature. You can find numerous articles on that. That's why neither of those were likely addressed in this particular episode. But again, I stated some of the things associated with a poor outcome. Again, going back to asystole, CPR greater than 25, dilated non-reactive pupils, pH less than 7, lactic acidosis, and then talking about the potassium itself greater than 12. So again, lactate, pH, less consistent prognostic significance, but we want to really look at kind of everything here. But this is also why we look at potassium and the rhythm itself. But I at least wanted to mention everything so that we can really approach this from all aspects.
No one has ever survived a cardiac arrest with a potassium over 11.
So here he states nobody has survived a potassium greater than 11 in a cardiac arrest. Now, that's a bold statement. I immediately go right to the literature and I do a literature search. Whether I'm looking at keywords, I'm looking at certain phrases. I personally have had a patient with 9.5 that survived. A few PubMed articles actually had a potassium of 10.2, another had 10.4, another had 10.7. In another article entitled Extreme Hyperkalemia, I'll actually post the link in the comments for you. It was published in 2005. It took a little bit longer to find this one. It was published in 2005 in the Southern Medical Journal that had a potassium of 14 that survived. And this is currently the highest reported potassium that survived. So small critique here. Again, I get where they're going with this, but to state nobody has survived a potassium greater than 11, that statement itself is wrong, and really he didn't need to say that. He could have just said, high potassium or something. Now, I would argue, now I'll give them credit, I will argue that in the setting of a pediatric patient with a potassium greater than 11, taking into consideration unknown downtime, hypothermia, the drowning, fixed and dilated pupils, prolonged CPR, rewarming, still asystole, that's 100% mortality. I would have favored saying more that part. So again, just some technicalities with this, but overall, the scene was very good. It was very realistic. I loved it.
There is absolutely no chance of recovery. I am so sorry. Amber has died.
No, it's not happening. No.
Before we stop, do you think her sister would like a chance to say goodbye?
No, Bella shouldn't see her like this.
Okay. You can stay in here for as long as you like.
It's okay. It's okay.
We are going to stop now. Resuscitation efforts discontinued. 1451.
Oh, sweet. I'm sorry.
I've said this before, but the hardest part in emergency medicine, or at least one of the hardest parts in emergency medicine, is pronouncing a patient, specifically pronouncing a child. Having to tell the parents, that their son or their daughter that's 5 or 6 or even younger, even older, just died is something that is extremely difficult. I would argue that the next hardest thing to do is you have a patient that comes in, cough, congestion, you get to know them just for, a couple hours during their ER stay or perhaps longer in their stay. They come in for one thing and you get some imaging done. Let's say they come in with, that cough or the upper abdominal pain or something related, and you get some imaging and it's concerning for a lung mass, or radiology is recommending further advanced imaging. Let's say you end up doing a CAT scan and it's highly concerning for malignancy. Obviously they need a biopsy and everything else, but they came in thinking, I got bronchitis, I got upper respiratory infection, I got something like that, and then having to go into the room and tell them, they have cancer, I would say is probably the second hardest thing that I have to do in the ER to pronouncing a patient. So overall, again, this scene is very realistic. It hits home, and it's very difficult to cover.
Bella, Dr. King and Dr. Collins are here.
Hi, I'm coloring.
You're a very good artist.
Thanks.
Bella?
Yeah?
What have you heard about Amber?
She's really sick, but the doctor and the nurse is trying to make her better.
Must make you sad. I have a sister too, and I don't like it when she's sick.
She saved me.
She did.
I fell in the pool. She helped me get out, but then she couldn't get out. I by making her a card.
Oh man, yeah, this scene gets me. I just have to take a deep breath with this one. This entire scene is, this is too realistic. This episode is tugging on heartstrings. So we learned that the sister helped save her younger sister before she drowned. That's hard. And again, I think this scene hits me so hard again is because my daughter's name is Bella. And when you find out that the sister helped save her younger sister, that's hard. So without that, both girls would have drowned. And so, you know, if I was doing a live reaction here, there's a good chance I would have some tears with this. So I'm glad I'm not doing a live reaction. And so this is actually my fourth take just in this scene, if we're just being honest, just because the first couple times I actually had to hold back tears just recording this. And again, if you say something enough, again, some of your emotions start going away. And even for my fourth time doing this, you probably can sense some of that still coming through. That's how difficult this scene is. This is how realistic the PITT has made this scene.
Freedom House took us in and trained us for 300 hours.
They turned out the very first medics in the United States.
We started IVs, defibrillated, intubated in the field.
They were the heroes of Hill District. Bunch of young black dudes saving lives every day.
Why'd you quit?
I didn't.
The city saw how successful it was, took over the program, trained new medics.
All white.
Everything that Willie and his friends did set the EMS standard for the entire country. Their program created the 911 system.
It wasn't just us. We had the best teachers. And Dr. Safa invented CPR. And Dr. Adamson, med student when I arrived. But I'm telling you, boy, that guy could teach like there was no tomorrow. You ever hear him give a lecture?
Many times.
Every time I save a patient, it's like he's standing right here, whispering in my ear, telling me what to do.
Me too.
Where's he working now?
Dr. Adamson died a few years ago during COVID.
Oh, hard to believe. He was so young, so full of life, force of nature.
Yes, he was.
So Dr. Adamson was only a medical student when this patient was in the Freedom House, and you can see Dr. Robbie's facial expression says it all.
We're back.
I should be out there for the honor walk. Right. Hey, Mrs. Phillips, your son would like to speak with you. Dr. King can stay here. Bella? Right? Yeah. Be right back.
I finished my card.
Oh. It's beautiful. I love it.
Thanks. Can I see Amber now?
Not quite yet.
What is that?
Oh, it's from the gift shop.
For Amber?
For you and for Amber. But you get to name it.
I think her name will be Bear.
All right. Since you can't see Amber right now, but I bet you got a lot of things to tell her, Bear's gonna help.
How?
Well, if you tell Bear everything you want to tell Amber, then I'll take Bear and sit her on Amber's pillow, and then she'll tell her everything you said. What do you think of that plan?
I like it.
Yeah? Okay. Do you want to give it a try?
Hi, Amber. It's me, Bella. Thank you for saving me. When you come home, I promise I won't touch your toys without asking. And I try not to fight because you're my best friend in the whole entire world. I love you.
Amber's gonna be so happy with that.
Ah, the pit, you are literally killing me. This episode is just bringing back too many memories, and this is just too real. Telling the parents that their son or daughter died and then having to tell the sibling that their other sibling died is incredibly difficult. This is a case I personally would not sleep for days. Going back to the child in residency I had with an open skull fracture, I could not sleep for a couple days after that. Even when you come back to the ER for your next shift, whether it's you get a couple days off or something, regardless of when you come back, you're still thinking about that case. You walk past that same room, you envision that patient still there. You still see them even though they're not there. You force yourself to compartmentalize. And in the emergency department, we get very good at compartmentalizing, right? You're in one room, something bad happens, you just shut it off and you go into the next room and it's as if nothing happened. So we get very good at compartmentalizing. It's the only thing that you can do in certain situations. It's what you can do to survive, to make it another shift, to treat one more patient. You have to be 100% focused on that next case. If you're in the middle of a resuscitation, it's a gunshot, you're doing all these things, you can't be thinking about the case that you just had. You need to completely shut that off and be in that next room. And with the emergency medicine, you're literally compartmentalizing every single case that you're getting. This is one shift. Now imagine 16 to 20 shifts a month. Imagine that many shifts per month, and then multiply that out by 12. Multiply that out by another 10 years or 20 years, however long you're practicing. So again, we get very good at compartmentalizing to treat one more patient, to save one more life, to be the best doctor that you can be, even though you continue to get beat up and beat down every single shift. But we push through. One question I got is, Dr. Taylor, why do you do this? Why do you push through? We push through for that patient that comes, to the ER that without the ER team, they wouldn't have a chance at survival. They wouldn't make it. They need us. Techs, nurses, doctors, we get up and go to work again and again and again, hoping that that next patient we can save.
Hey. How long have you been working here?
32 years.
All in the ER?
Yeah.
Oh, man. How do you do it?
I like taking care of everyone, especially the ones who fall through the cracks. They got nowhere else to go.
Well, you deserve a medal.
I'd settle for a raise.
Not enough medals in the world can be given to our ER nursing staff, and all nurses for that matter, that come to work every single day to provide outstanding patient care.
Thank you for everything.
I wish I could do the surgery here.
Surgical teams are flying in from all over the country to meet Nick at the Center for Organ Recovery.
We have a car and driver waiting so John and Lily can follow right behind the ambulance.
Thank you. So we won't be seeing you again?
If it's all right, I think a lot of us here would like to attend Nick's funeral.
Yeah, of course.
So I wanted to talk about the honor walk before it happens. Now, the last few critiques, the last few episodes, I spoke about how the honor walk normally does not happen in the emergency room. This happens on the floors, this happens in the ICU. And as such, this scene is not realistic at all. But again, we want it to happen in the emergency room for this show. So again, this normally does not happen in the ER, it happens in the floors in the ICU. But let's talk about the honor walk, since in the TV medical drama, it's gonna be happening in the ER. So for those not familiar with what an honor walk is, we're gonna briefly talk about that. Every individual that has made the decision to donate is a hero. And that has made, they made the choice to both save and heal lives. Because of this, That individual deserves to be commended. It's a ceremony to be celebrated. You know, they're to be honored. This brings us to the honor walk, a truly powerful gesture that shows the family of the donor that they're not alone, that everyone around them is grateful for the gift. In addition, it allows for the hospital staff as well to participate and to recognize the true heroism of this patient.